experiments. So the first work I will try to introduce is like how we adapt the generic large language model like ChatGPT you may be aware of for literature research in medicine. And specifically, the target of this pipeline is to accelerate the clinical evidence synthesis from the literature. For example, this is a pyramid of clinical evidence, different types of clinical evidence you can find from the medical literature. From the bottom one, we have the lowest quality, unfiltered information of clinical evidence, like some expert opinions. Then going up, we have higher quality ones, some case reports, then go to the randomized control trials, you have better quality than just like cohort studies. And at the very top of this pyramid, we have systematic literature reviews and meta-analysis. So this kind of evidence represents the ones which undergo the like expert reviewing and the filtering of the information, those unfiltered information from the literature. And they are regarded as the highest quality evidence you can find from literature. So people are doing these reviews very frequently. One example of clinical evidence you can get from these reviews are like in a meta-analysis of a couple of studies for those patients, you find a specific disease X and drug Y can reduce its mortality rate by some percent compared to the other drug. So this kind of evidence just directly applies to improve the patient outcomes. Like you can enhance the clinical decision making in the future because it suggests that drug Y may be more useful to treat, like to improve the patient survival for this disease X. The other type of evidence that can benefit from clinical trial designs, like you have a meta-analysis of several studies, and you find that specifically a subpopulation, for example, a patient with a gene mutation, experience just like better outcomes in terms of survival compared to those populations who do not have this gene mutation. So this is kind of biomarkers which are frequently now used to identify the target subpopulation to develop new treatments. So this kind of evidence, if you can find and create, can help you plan for your new clinical trial, right? For example, maybe develop new target therapy for disease X, right? Patients for this subpopulation using drug Y. But this review is quite useful and helpful, and people are doing that a lot. But there are indeed several challenges, right, doing this review. And the first one is this. I just take an example of which called Prisma flow, and it's a common figure people report in their review paper. It basically describes the workflow, how they formulate their review, like from identifying the data sources from like publications from multiple data sources, like EM-based PubMed, and then goes to like very complicated and manual process of selecting the target studies by reading their titles, abstracts, full text, and go to the final subset, or very small subset of the 1,000 articles, for example, 30 or 20 of them, you are using them to analyze, like to read the full content, extract the results, and do the qualitative and quantitative analysis. So this process itself is quite complicated, but which makes it worse is like the PubMed, like the literature database is growing very fast right now. This is like a distribution of like number of PubMed index papers over time from like 2018 to 2023. And now there are like over actually 35 million plus medical papers you can find from PubMed. And also people are doing systematic literature review very frequently. Like I just did like a very quick search on keyword search for SLRs in like on PubMed, you get like 50K around like this published SLRs annually, just roughly search. So the need for doing review is high, and the literature database is growing fast. And this has caused the result that now it takes more and more efforts manually, like on average 5 experts, and over a year. And this is from a study reports that this amount of effort has to be made to like actually get a review completed and published. But since the literature is growing fast, so after this a year of process doing review, the newly generated review, the new evidence may just become outdated very fast because like this process just so long. And so this is our motivation to build this pipeline, since LLMs, as we know, like are very powerful in like processing some information, give us like streamline the information, like understanding of some information. So the question is how we adapt LLM to a pipeline that can seamlessly integrate it into this process. So let's get back to this example workflow. We can decompose this workflow into several steps. Right? First step, identifying the publications from different sources. So this is like a study search process. Like we can use LM to enhance the study search. And the second component is to selecting, like after you have identified 1,000 more studies, you have to read the abstracts, read the titles. So this is like more of a study screening process with some predefined eligibility criteria of your target studies, and to make sure which one are the exactly you want to involve in your final analysis. And the last step is like to, after you have finalized your study cohort, the candidate studies, you want to extract the data, right? The study design, the study characteristics, and also the results from the studies, as well as like aggregating those results into some kind of meta-analysis to get aggregated outcomes. So with this decomposition, we further want to develop a pipeline with a platform that a user can interact with LM with no coding, and to like streamline this process as well. So we have this pipeline like has like 4 steps. Like this video just showed the first step. You have your research question, which is defined in the PICO framework. Like PICO means like population, intervention, comparison, and outcomes. So here we have defined the population, like patient with refractory or relapse, like hematologic and solid malignancies. So this is like your definition of a research question for which population you are targeted for, and also the intervention, CAR T therapy, and some outcome of interest. So with this kind of question, a research question definition, we can start the analysis. Well, we can trigger LLMs to generate these search terms and also sample more search terms in terms of which keywords, like treatment terms and condition terms, you derived from your research question. Then we can like use these search terms and LLMs to fetch the studies and rank the studies by their relevance and get the initial identification of the candidate studies. And this becomes the solid starting point. While the recall of this process is quite important, because if you cannot find the target studies from your initial search, whatever screening you did, you will not find your target studies. So we have evaluated the recall, like how many % of ground truth target studies we can find using our platform, compare with to just ask ChatGPT to help you generate a term and find it from the internet. So we have like TrialMind recall with over 90% most of cases, over vanilla GPT baseline that can get like a 10% or even lower ground truth studies from the search results. And we also have like human baseline, which we just ask annotators to extract the keywords from the research question and use these keywords to search studies. So this has lower like coverage than the TrialMind pipeline, because these keywords may not necessarily be identical to the ones you find in the publications, right? Usually you need to augment it with different variations, like some abbreviations and so on, to improve the coverage. So that's how our pipeline can get a high recall than this human-based and vanilla GPT baselines. The second step is the study screening, right? You have identified your initial study list, and we can define the eligibility criteria based on your research question, like if it's clinical trials or if it's indeed target for blood cancer or solid cancer patients and so on. So we have this LM suggested criteria, and you can also edit this as you want or add new criteria. And with this criteria, we can trigger our AI agent to read the title and abstracts of all these involved studies and just predict the eligibility of each study for each criterion by like eligible or ineligible, or just not enough information because we cannot find that information from the abstracts. So with this like very clear eligibility prediction, we can do some kind of ranking and filtering. So you can rank the studies which meet the most eligibility criteria you set at the top. So you can quickly find the ones you want to read, then you want to involve in your like data extraction stage. Then after you have like selected the studies from the top, right, you have the ranking, and then you select the studies. Then the next step is to extract the data from those like publications. So our platform like pipeline adjusts the LLM to do this task. Like you can define the target field you want to extract, for example, the number of patients, or like the other participant flow related question, like follow-up period, or population statistical information, like the average age and so on. So it's quite flexible. You can just define this target field, and we will just pass this description of the target field, and to trigger our AI agent just read those papers, the full content of those papers, and try to get a structured outputs, right? You can populate this table with new new data fields you have just defined, and you can then just draw this table and to get a further filtering, or just like synthesize some aggregate information, like average patients they recruit from this type of clinical trials. And we have like tested our pipeline specifically optimized for data extraction from medical publications. And this pipeline has been better than the vanilla GPT prompting baseline by like a margin of over 15% accuracy. And the last step is to synthesize the evidence, where you want to define your outcome measurements, for example, like some complete response rate or overall response rate, and some of the other outcomes, whatever outcomes you are interested in and exist in the involved studies. Then you can also define some kind of grouping strategy, which is like the target subpopulations you are interested in. So we have this interface, you can define this setup and just extract the target outcomes from those studies. So here, this is so-called forest plot. You have like each row is a result from one study, and also the aggregating information from all of those studies, which is a very like solid quantitative evidence you can get from the involved studies. And this is like what people will report in their review as a meta-analysis and get this like a numerical evidence. So we have conducted a user study like for 5 reviews. We use our platform to synthesize this evidence, and also have a ChatGPT plus human, like you can upload your the target studies as a PDF and chat with those PDF to get the evidence. So we have 8 annotators, and most of them prefer our like outputs, right? Over the current practice, people just work with ChatGPT. So in this paper, we have like discussed how we adapt the generic LLM with some special prompting or RAG or something like that to improve the task, like the medical literature mining task. And next, I will introduce like how we develop specialized LLMs, like not just based on ChatGPT, but how we have a special LLM just for medical literature mining tasks, which is this LIS paper. So our motivation becomes to train LLMs, you need a large amount of data. And for literature mining, there are actually a lot of open literature data we can leverage, right? For example, clinicaltrials.gov, you can easily find 500,000 more clinical trial records. And from the medical publications, you can find from Cochrane, PubMed Central, and there are like tens of millions medical publication. And from them, you have maybe 2 million more are actually clinical trial publications, and also systematic literature reviews. But the question is, we can indeed collect this raw data, but to build a specialized LLM, you need a special format of this data, which is called instruction data, right? It describes the task and has the ground truth outputs for the task. But from those raw data, they just do not have this type of format. We need to convert this to instruction data following format to exactly fit our need for the task, for like this task of study search, screening, and data extraction. So this is a core question: how we can leverage this whole enormous public literature data to build a specialized LLM. So we start from the source data, like reviews, publication, clinical trial design information. And for the first 2 tasks, we can leverage the links between the reviews and the studies involved in their analysis, right? We actually have find 20,000 more reviews with such linkage. And this linkage is useful for the first 2 tasks because they are all about finding the target studies. So this is an example review paper. And usually this type of paper has one table, which we can call table 1, has the characteristics of the involved studies in their review. So from this table, the first column, the reference, so those are the ground truth studies, right? If you do the study search and you try to reproduce this review, the target of the target involved analysis, the studies to be analyzed are those studies they involve in their table 1. And the other columns, for example, like sample size, median age, like lines of prior treatment and so on, they are the target data from those publications, which were manually extracted from the authors of these reviews and can be treated as a ground truth, like human annotated high quality target data to like extracted from the publications. So for task 3, we further formulate this data extraction task by linking the publication and the clinical trial records. So for example, this is like one clinical trial paper, right? It has a NCT ID linked to this, like NCT number linked explicitly mentioned in these abstracts. So we can then find clinical trial records, right? These records from this website has exactly the structured data, like the sample size is an integer with 26, and like target condition, list of like keywords of the condition terminology. So this naturally becomes the target, right? If you have an unstructured publication document, you can ask LLM try to extract the structured outputs as we can find from clinicaltrials.gov. So it's quite rich. It has many kinds of like target data you can find, like participant flow, the baseline, outcome measure, adverse events, and all of those like results and study design related information. So with this strategy, we can create a very large instruction data, and it actually has like 20,000 reviews and hundreds, thousands of publications and clinical trial records. And this has become the largest, to our knowledge, the largest training and testing data for medical literature mining tasks for search, screening, and extraction. So then the next story will be quite straightforward, right? You have already got instruction data with clear, like high quality human annotated outputs. So we just do the so-called supervised fine tuning, like to train a generic large language model like Mistral, exactly in this case, and to adapt this model by this fine tuning to be a specialized model we call this. And then we just perform an evaluation of this model with comparing it with like larger and those generic LLMs like GPT-4o as a cutting edge model you can use for out of box from like generic domain. And we just find this lightweight model just with a simple like supervised fine tuning can already outperform this generic model on all types of these tasks we like from literature mining related tasks like search query generation, like for study search, eligibility prediction for citation ranking, and so on. And what's more, we want to evaluate, like, since this model has a quite good performance, then we want to know, okay, when we have a medical expert working with this model for the time-consuming part of literature mining, for example, screening, then how would the performance differs compared to the one that expert just working on that manually, right? This is what we're interested in, the practical value of this type of model can bring. So we have these two arms, experts working with AI versus expert only. And we have invited like 16 clinicians and medical researchers from 14 institutions. And we invite them to do this user study and observe comparable like a quality of their screening results, and with like over 20% time savings in this process. So it indeed introduces some efficiency improvement, but we want to highlight the case that we are just doing a simplified user study here. Like we assign each human participant with like 30 studies, and they are ought to find 10 targets from this 30. But in real case, you are just doing study screening, you are encountering many more studies than 30, right? For example, maybe 300 or even 10, like 1,000 studies you want to screen. So this becomes like much harder, right? If you want to select like 10 targets from 300 studies, then this becomes quite sparse, right? If you need to rate them entire, and if compare with you have AI to rank them, definitely when more time saving will be expected. But we want to leave that larger scale user study in the future. But we do have some proof that may happen exactly, because we have this like confusion matrix. We show that what experts selected and what our model believe should be included in this systematic literature reviews. And we find that from this confusion matrix, expert and our model's idea are quite consistent. So from the studies which were not selected by experts are also the studies which were believed that our model believed that shouldn't be involved, like with very low scores. So we exactly have some clinician participant comment on that when he or she refer this AI outputs, usually you can like safely exclude the low score studies because they have no chance to be involved. They are just too irrelevant. And so we can just expect that with many more candidates, you can use AI to exclude those studies which are definitely irrelevant, and then just focus on, like, even have 1,000, you can just read the top 100 to finalize your final study analysis study list. So we will try to explore that time reduction, how big it will be in the future. So this is a kind of like overview of the first part. Right? We can use AI to streamline the review process, extract the previous study design, their characteristics, and also synthesize their evidence, right, to provide your hypothesis and also maybe inform your clinical trial design.